Keeping up with cardiovascular research. Specifically, we're diving into that top 10 papers in heart failure of 2024. This is based on a great review in the European Heart Journal from, well, 2025, looking back. Our plan today is to unpack the biggest breakthroughs from last year. We'll start with heart failure with preserved or mildly reduced ejection fraction, HFpEF, and HFmrEF.
Historically, treatment options were pretty limited beyond diuretics, but then we had the SGLT2 inhibitors coming through with EMPEROR, PRESERVE, and DELIVER.
Right.
But 2024 brought some really interesting new players into the mix for these patients.
Okay, let's jump right in then. First up, finerenone, the FINEARTS HF trial. This is a non-steroidal MRA, right?
Yeah.
A bit different.
That's correct. Not like spironolactone or eplerenone. FINEARTS HF looked at over 6,000 patients with HFpEF or HFmrEF.
And headline finding.
A clear benefit. They found a significant 16% relative reduction in the main composite outcome. That was total worsening heart failure events.
Okay. And what drove that result? Was it the hospitalizations or the deaths?
It was mainly driven by fewer worsening heart failure events. For cardiovascular death, there was a trend downwards, hazard ratio 0.93, but it didn't actually reach statistical significance on its own in this trial.
Got it. Important distinction. Any safety flags we need to know about? MRAs always make you think about potassium.
Exactly. And yes, they did see a higher risk of hyperkalemia with finerenone. Interestingly, also a lower risk of hypokalemia.
Okay, so careful monitoring is key then, especially with kidney issues or other meds affecting potassium.
Absolutely critical. Vigilance is needed there.
Right. Now, let's shift gears slightly. We know HFpEF often goes hand in hand with obesity and type 2 diabetes. The STEP HFpEF DMDRO trial looked at semaglutide here.
Precisely. This was a really interesting one. Over 600 people with HFpEF, obesity, so BMI 30 or more, and type 2 diabetes, randomized to either weekly semaglutide, the 2.4 milligram dose, or placebo.
And semaglutide's impact, often dramatic weight loss, but what about HF symptoms?
Both, actually. Quite striking results. The semaglutide group lost significantly more weight, mean reduction of 9.8% versus only 3.4% for placebo.
Wow.
That's a difference of 6.4 percentage points. Highly significant p-value. But crucially, also, big improvements in the KCCQ clinical summary score. That's a quality of life measure for heart failure.
How big an improvement are we talking?
Average jump of 13.7 points with semaglutide versus just 6.4 with placebo. Again, p less than 0.0001. That's a clinically meaningful improvement.
That really is significant for patient symptoms and daily life.
And C-reactive protein levels went down too. Oh, and numerically fewer heart failure hospitalizations, though the trial wasn't powered for that specifically.
Okay, so a positive signal there too. Now, staying with incretin mimetics, there was also the SUMMIT trial with tirzepatide. This one was powered for HF outcomes, wasn't it?
Yes, exactly. SUMMIT was the first trial with these agents specifically powered for HF outcomes in people with HFpEF and obesity. They used tirzepatide up to 15 milligram weekly.
And the results?
It hit both primary endpoints. First, a significant reduction in the composite of CV death, or a first worsening HF event hazard ratio 0.62, so a 38% relative risk reduction. P-value 0.026.
Okay, positive on heart outcomes and the KCCQ.
Also significantly better, the change from baseline to 52 weeks in the KCCQ-CSS was much greater with tirzepatide.
Do you have the numbers for that?
At 52 weeks, the mean KCCQ score was 19.5 points higher with tirzepatide compared to placebo. And similar to semaglutide, they also saw benefits in 6-minute walk distance and CRP levels. It really looks like these GLP-1s or dual agonists like tirzepatide have a major role emerging in this HFpEF phenotype.
Definitely seems that way. But what about side effects? Tirzepatide often comes with more GI issues, right?
Drug in the tirzepatide group? Mostly gastrointestinal stuff, as expected. It was 6.3% discontinuing versus 1.4% with placebo.
So, noticeable.
Yeah. It's generally in line with the class effect, but it underscores, the need for good patient counseling, starting low, going slow with the dose titration, maybe being more cautious in certain patients.
Good points.
Yeah.
Okay, one more in the HFpEF space, but a different angle. Pulmonary hypertension is common. The PASSION study looked at tadalafil, a PDE5 inhibitor.
Right. The thinking was, could tadalafil help HFpEF patients who also have combined postcapillary and precapillary pulmonary hypertension? So they randomized patients to 40 milligram tadalafil or placebo.
Did it work?
Well, the study actually got stopped early. Issues with medication supply, unfortunately.
Oh, okay. So inconclusive.
Not entirely. For the primary endpoint time to first HF hospitalization or all-cause death, there was no significant difference, but and this is the really critical part, there was a concerning signal.
Concerning how?
A possible higher risk of all-cause mortality in the tadalafil group. The hazard ratio was 5.10, p-value 0.04.
Wow, 5 times higher. That's
Mm.
striking. So the takeaway is caution.
Extreme caution. The authors basically concluded, don't use PDE5 inhibitors broadly here, maybe only in very select cases in expert centers. Okay.
Well, let's pivot now to heart failure with reduced ejection fraction. HFrEF, guideline-directed medical therapy, GRMT, is key here. We know we need to optimize it for at least 3 months before thinking about an ICD if the LVEF is still low. But the HFOPT study asked, well, how long can that LVEF improvement actually continue during optimization?
Yeah, it's a good question. They took patients with newly diagnosed HFrEF, EF 35% or less, who got a wearable defibrillator, a WCD. They followed them, tracking their EF over time up to a year.
And what did they find about that recovery timeline?
It was quite revealing. Almost half, 46% of the patients whose EF was still low, less than or equal to 35% at day 90, actually improved to above 35% by day 180.
Really? So nearly half of those who look like ICD candidates at 3 months weren't candidates at 6 months.
Exactly. This pushed the total rate of improvement above 35% up to 68% by the end of the year. And importantly, the risk of serious arrhythmias, sustained VTs, was pretty low after that initial 90-day period.
So the implication is maybe we shouldn't rush to implant an ICD at the 3-month mark. Give optimization more time.
That's certainly what it suggests. Extending that optimization period beyond 3 months might prevent a good number of potentially unnecessary ICD implants. Worth considering.
Okay. Next up, PA pressure monitoring. Pulmonary artery pressure-guided therapy. Monitor HF looked at this, and there was a sub-analysis trying to see if certain subgroups benefit more.
Yeah, the perennial question, who really gets the most bang for the buck with PA monitoring? So they sliced the monitor HF data by age, sex, comorbidities like AFib or diabetes, baseline EF, whether they had a device already, all sorts of things.
And did any particular group stand out?
Nope, that was the surprising thing. The benefits in terms of quality of life, clinical events, lowering PA pressure were remarkably consistent across all the subgroups they looked at. No real significant differences in treatment effect.
Huh. So maybe we don't need complex algorithms to pick patients.
It kind of suggests that our current approach, often based on identifying patients with significant functional issues after a recent hospitalization, is probably reasonable. It doesn't seem like these other factors drastically change who benefits.
Interesting. Okay, now on to a topic that's seen some back and forth. Transcatheter mitral valve repair for functional MR in heart failure. ReShape-2 tackled this.
Yes, the debate around co-APT versus mitra definitely fueled interest here. ReShape-2 took 505 patients with HF and moderate to severe functional MR, randomized them to the transcatheter repair like MitraClip plus GRMT or just GRMT alone, followed them for 24 months.
And the verdict from ReShape-2, did repair help? These results really seem to add weight to the pro-repair side, don't they? Especially after the conflicting signals earlier.
They really do. A significant benefit in the device group. They saw a 36% relative reduction in the rate of total HF hospitalizations or CV death, rate ratio 0.64, p-value 0.002.
Okay, positive on the composite. What about hospitalizations alone?
It also significantly reduced. A 41% relative reduction in total HF hospitalizations, rate ratio 0.59, p-value 0.002. And patients felt better, too.
Ah, the KCCQ again.
Yep. Big improvement in the KCCQ overall summary score in the device group.
How much better?
Let's see. Improvement of 21.6 points with the device versus just 8 points in the control group. That's a difference of almost 11 points. Highly significant. It provides a much stronger foundation now for considering transcatheter repair in these carefully selected HFrEF patients with...
Now, for patients with the most advanced heart failure, LVADs, left ventricular assist devices, are a lifeline. The Elevate registry gave us some real-world data on the HeartMate 3.
Right. The HM3 is one of the main continuous flow LVADs used long-term. Elevate tracked 463 patients who got one in regular practice.
What did the long-term outcomes look like? Survival? Stroke?
Pretty encouraging, actually. The 5-year overall survival was 63.3%, and stroke-free survival at 5 years was 58.1%.
Okay, so decent long-term survival. What about quality of life? That's huge for these patients.
Absolutely. And the registry showed substantial and, importantly, sustained improvements in functional capacity and quality of life over those 5 years.
That's really significant, isn't it? Suggests that modern LVADs aren't just buying time, they're buying quality time for many end-stage patients.
That's a fair assessment. good long-term survival with an acceptable stroke rate, and meaningful QL improvements. It's a vital therapy.
Sticking with LVADs, managing anticoagulation and antiplatelets is always tricky. Bleeding versus clotting. The ARIA's HM3 trial asked a specific question about aspirin.
Yeah, specifically in HeartMate 3 patients already on a vitamin K antagonist like warfarin, do they also need aspirin? So over 600 patients were randomized. Either stay on aspirin or switch to a placebo.
And the primary endpoint, they were looking for non-inferiority of not giving aspirin, right? In terms of major adverse events.
Exactly. Survival free of major non-surgical hemocompatibility events, things like stroke, pump thrombosis, major bleeding at 12 months.
And did placebo prove non-inferior?
Yes, it did. In fact, the event-free survival was actually numerically higher in the placebo group, 74% versus 68% in the aspirin group. The stats confirmed non-inferiority.
So the key takeaway is you can likely skip the aspirin in HM3 patients on warfarin.
It strongly suggests that. Avoiding aspirin seems to reduce bleeding complications without increasing the risk of thromboembolic events like stroke or pump thrombosis. That's a pretty major finding for simplifying management and potentially improving long-term outcomes.
Huge practical implications. Okay, last paper for today, a different population. Peripartum cardiomyopathy, PPCM, and the role of bromocriptine.
Right. PPCM is rare, so big RCTs are tough. Bromocriptine has been proposed as a treatment targeting a specific pathway, but the evidence has been, evolving.
So what did the EORP PPCM registry add?
This was a large, non-randomized registry analysis. They compared outcomes in 552 women with PPCM. 85 of them received bromocriptine on top of standard HF care.
And what did they find comparing those treated with bromocriptine versus those who weren't?
They looked at a composite maternal outcome: death, HF readmission, or having a persistently low EF below 35% after 6 months. And the incidence of this composite was significantly lower in the women who got bromocriptine.
How much lower?
It was 22% in the bromocriptine group versus 33% in the standard care group, p-value 0.044.
And they adjusted for potential differences between the groups. Okay, any difference in side effects like blood clots? That's sometimes a concern with bromocriptine.
Good point. They reported similar rates of thromboembolic events in both groups in this registry.
So this registry data adds more weight to using bromocriptine, maybe particularly in more severe PPCM cases.
I think that's a fair summary. It provides further supportive, albeit non-randomized, evidence for considering bromocriptine, at least in patients with moderate to severe PPCM, alongside their standard heart failure therapy.
Wow. Okay, that was a fantastic run-through. We covered a lot of ground: HFpEF, HFrEF devices, specific conditions like PPCM. Some really practice-changing stuff in there.
Absolutely. From new drug classes making inroads in HFpEF, to optimizing therapy timing in HFrEF, refining device use, and even insights into rarer conditions. It really highlights the dynamism in the field.
It certainly does. Well, this has been some of the key findings highlighted in the top 10 papers in heart failure of 2024. If you're a cardiologist looking to stay on top of the latest evidence-based research in contemporary cardiology, we invite you to subscribe to our podcast, Evidence-Based Cardiology Talks.
That's right. You can find and subscribe to Evidence-Based Cardiology Talks on both Spotify and YouTube. That way you won't miss future deep dives into crucial publications like these.
And we should mention, this analysis was conducted under the supervision of Dr. Caroli, a practicing cardiologist. You can find out more about his work at drcaroli.com.